Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, my name is Stephen Shaffer, and I'm honored to welcome to the show Drs. Will Kolb and Jodi Young. Dr. Kolb earned a Master's of Physical Therapy from Old Dominion University and practiced in a variety of settings before returning to school and completing a clinical doctorate from Regis University. He then completed board certification in orthopedics, as well as a fellowship program recognized by AAMPT. Currently, Dr. Kolb is a full-time associate professor at the Radford University Doctor of Physical Therapy Program, where he teaches content related to orthopedics, complex case management, and health policy. Dr. Young is a faculty member and the Assistant Director of Research in the Bellin College Doctor of Science in Physical Therapy program. She is a board-certified orthopedic specialist as well as an AAMPT Fellow. Additionally, she is currently working on a PhD through the University of Newcastle in Australia. Dr. Young has been teaching in entry-level DPT, residency, and fellowship programs for 10 years, and has taught a wide array of topics related to orthopedics, manual therapy, and research methodologies. We invited Dr. Kolb and Dr. Young to the show today because, along with their colleagues, they recently authored a paper that was published in the Journal of Manual and Manipulative Therapy titled, "The Evolution of Manual Therapy Education. What Are We Waiting For?" Speaking of which, without any further delay, let's get to the interview. Dr. Kolb, welcome to the podcast. How are you doing?
Excellent today. Thanks for having us.
And Dr. Young, a warm welcome to you as well. How are you today?
Thank you. I'm doing great. Happy to be here.
Well, we are also happy to have both of you. This is a very exciting paper. Obviously, in recent, let's say, months and years, this has been a topic of conversation. And building off that point, I'd just like to start by asking both of you, how was it that this project came into existence?
Hey, that's a great question to start with. I think this was a fun project for us to work on, and I think it really came out of our conversations that we had with the academic and clinical faculty SIG of AAMPT in talking about our experiences with teaching at entry level and teaching in residency, and some of the conversations that we were having out there with our students about how to integrate manual therapy and how to integrate the biopsychosocial model and so on and so forth.
And I would just add too that, we all come from different backgrounds. So we talked a lot about maybe there needs to be a more standardized process, or is there some way that we could all come together, because we were just hearing such different stories from our students. And we thought it would just be a great idea to kind of put something together and then see what people would do with that. And if we could kind of reach a consensus of where we should go in the future.
Yeah, that sounds amazing. And I can say from my personal experience, having studied multiple different approaches to orthopedic manual physical therapy, it really is it's a treacherous process to try to learn it all and to try and put it all into a package that you can neatly use in the clinic. And
I would agree with that. I think that when we compare our differences at entry level, residence, and fellowship education, we still have difficulty defining what makes an expert truly an expert, and then how do we evaluate that, or how do we assess that across those levels. One of the points of this article is how do we bring that back home to teaching manual therapy, and how do we make that effectively work for our students, and how do we get them to understand that it's more than just one little mobilization that's the treatment, that there's a lot of different aspects that go into successful treatment.
Before we go down that road too far, let's go back here a little bit. And part of the driving force for this paper was the fact that individuals and groups of individuals have made some observations about manual therapy that are perhaps on the more negative side. And in particular, this has occurred in some editorials. Can you talk to us for a moment about what those have said and what people are in general saying about manual therapy within our profession?
Oh, exactly. I think that there's been a string of editorials in JMMT about how manual therapy is not fashionable. It's in a crisis and it's got a questionable future. And I think all of these are like the nice words that were used in the editorials. I mean, social media has not been as kind as as what our own professional editorials have depicted manual therapy and its use.
Yeah, I think that, with manual therapy, what we have found in the research is that, the short-term benefits are there, but there's no long-term benefit. And I am, heavily interested in the exercise aspect of physical therapy. However, I think there are times when manual therapy is still beneficial. So I think we can't fully throw away manual therapy just because there's stuff out there that indicates, it only works in the short term and exercise trumps everything and everyone benefits from exercise. I do think that there's really an element that manual therapy brings, and this is where this whole biopsychosocial component comes in, because you can really directly address each of those components with manual therapy, even though it would seem that it only would address the bio part of the biopsychosocial.
And I will admit fully here that I bias my clinical practice more towards manual therapy than many of the clinicians I know. And one of the interesting things that I see is that sometimes I can get vastly superior results. And maybe that's the way I'm implementing or dosing my manual therapy. Maybe it's the way they're not, or maybe how they're approaching exercise, etc. There are always so many variables at play here that it's hard to directly compare everything and know exactly what's going on. And oftentimes, as we all know, there can be more than one way to get to the same solution, which in this case is your patient getting better.
I would totally agree with that. I think that that's part of what we do as experienced therapists. I think that we look at more than just what's on a script or what we've learned in school. We're able to integrate our clinical reasoning, our narrative reasoning at different levels and develop that therapeutic alliance with the patient. And I think that's really what we're trying to pull out in this editorial was that we can't just oversimplify it and just teach passive mobilization or manipulation. It's a sum of a greater whole package, I guess, if you would, for the use of manual therapy combined with that therapeutic alliance, patient expectation, etc.
Well, and I would add that, I mean, that therapeutic alliance that's being talked about so much, right, in recent years. And I think there's that element, and I think Will and I actually had talked about this recently, where I was a new grad. I used a lot of manual therapy because I loved it right away, but I didn't have a lot of training in it at that point in time. And yet I still felt like my patients were doing really well. Well, maybe it was because I had developed that rapport and I was really hitting on that therapeutic alliance piece. But also, my patients were expecting that when they came to therapy, I was going to have something beyond just exercise, that they were expecting that I was going to do some hands-on treatment. And just between the bio element where, yes, maybe I was doing something with my manual therapy, but beyond that, I was making a connection. So I had that therapeutic alliance and I was addressing their expectations, and you wrap that up, and then ultimately the outcomes were really good.
So as we all know, manual therapy is more than just manual therapy. There are a lot of different variables involved in that process. And in the case of my clinic, that even involves the waiting room. It looks a certain way, it sounds a certain way, and the number of times that a patient says something like, you know what, I could just come in here, sit down, and read a book, and it would be a perfectly pleasant place to spend time.
Oh, isn't that wonderful when you've already got that type of a buy-in from your patients? I think, with some of our management classes that we teach here at Radford University, had a local clinical operations leader come in, and one of her comments that resonated with the students was, "You haven't made it until you have your name on the script from the physician." And you think about that, and how is the physician sending that order over, or how is the physician communicating that need for therapy with that patient. That patient's already set up with a high expectation of how to improve. Hey, I've got to go see Stephen, or I've got to go see Jodi because my physician recommended them and said they're going to help me heal faster, or they get really good results compared to some of the other therapists in our local area. And so we've already set up this positive expectation with that.
Yeah, I would add to that completely. I mean, I think about some of the mentors that I've had, and one mentor specifically called out by name all the time, referred to from physicians. And right away, I've actually been a patient myself there. And right away, you think, I'm going to get better. I know I'm going to get better because this is the expert. He knows exactly what he's doing. And guess what? You do get better. So I would agree completely with what Will just said.
Thinking back to the big picture now, why do you think the pendulum is in part swinging away from manual therapy at this point in time?
So I think there's really a multitude of reasons. I already touched on how research has shown, there's really the short-term benefits, but we don't have any long-term benefits to manual therapy. I also think that there's been such a rise in the pain science, the neuroscience education aspect of research. So that's being implemented in programs more often. Students are learning about it. They think it's just this awesome thing that they can implement into practice. So then maybe I don't need as much manual therapy. I also think there are so many other courses that are coming out. You see cupping, dry needling, all these different options. And it's a little bit like, what's the shiny new toy, right? So manual therapy, all the studies that came out about it, there's many of them, but it's kind of swung away from that as far as what the focus on research is. And there are all these other elements. And so I think that people are moving away from that. And I can specifically say when I do some mentoring for residents, they're really heavy into the pain science component now. They really want to address that. They want to make sure they are addressing it. And I think that's great because that was something in my world when I was in PT school, we really didn't even talk that much about it. So overall, I just think there are so many new areas of research. I think students are exposed to a lot more. I would say the social media piece comes into play there, and they see so many other interventions that you could potentially use that even though students really love the manual therapy, I mean, that's one of their favorite classes. Whenever I've taught that, they just love doing the manipulations. But I see that they also like and respond to all of the other options that are out there.
Yeah, and I would add to what Jodi said too. I think part of it might be now with the focus in our profession on the science behind the science. And as we look back at trying to delineate like effects of manual therapy, we've had to take them out of the context in which they're provided. And so research isn't as kind when you take away the context, and maybe you take away some of the bias of the actual person that's doing it, I guess, when you put it in more of a sterile environment. But I think that's kind of what happens to a lot of our therapeutic interventions when we take them out of the context that they're provided in. And the difference is with the pain neuroscience. I think that is a little bit maybe nicer for us to research and to prove, maybe possibly at this point in time, that it's more effective when you deliver it in like a very sterile environment, not as much about like the real world practice type of environment.
I certainly agree with all of that. And one of the problems here, of course, is the fact that none of this can really be fully disengaged from the other components. I mean, we keep bringing up the phrase, the biopsychosocial model. The phrase in itself has three components. It's got the bio, the psycho, and the social. And if you go back and read Engel's work from 1977, including the critiques that have come since then, I don't think anyone's really saying that any of these individual parts can be fully separated. If you're just bio, you're approaching things too narrowly. If you're just addressing psychological variables, it's the same outcome. And I think in terms of what I've seen in the clinical world, the physiotherapy profession in general is doing an overall good job trying to integrate all of these, with manual therapy being just one part of it. But I still don't think we've found that sweet spot where we know exactly a formula, an approach, an overall equation that can be implemented in the largest number of situations to get the best results.
Well, I think one thing, and this goes back to the point of our editorial, right? We are working with entry-level residents and fellows. And I think in the entry-level world specifically, where I spend a majority of my time, is students have a course where they learn manual therapy techniques. Then they have a course on psychosocial. And then, how do they integrate all of that? So they end up siloing the information. That's just how we learn. And there's so much information coming at them. It's hard to intertwine and connect those courses, right? So unless you're in a class where you're teaching manual therapy and you're bringing in the other psychosocial component, then it's hard to integrate those two. And I think from a teacher's perspective, that is difficult because you only have so much time. So as much as you would love to integrate some of the other things they're learning in different parts of the curriculum, it's not always threaded so easily. And so I think that translates then when people go in the clinic, then they have trouble bringing all of those together because of how they've learned it. And it wasn't necessarily packaged nicely all together when they initially learned it. Now in residency and fellowship, you start to hone those skills more. And I see that develop more as I've worked with residents and fellows, but it still is somewhat difficult to bring those all together because sometimes they end up getting stuck on one component and addressing that. And I really specifically think entry level students struggle with that because they're just trying to get the skill down of manual therapy. So how could they possibly think about all those other components when they're just trying to do a great mobilization or manipulation with that patient in front of them?
Yeah, I think Jodi's spot on there with that description. And I would just add to that in saying that as our students learn and grow more, then they're able to integrate these things. But I think that one of the points we were trying to get across from the editorial was that let's not take out the psychosocial from the bio of what is a manual therapy skilled intervention provided by a expert practitioner. I think that, even as we've kind of separated out the pain neuroscience and that type of treatment, I think that we've taken for granted that that is a different part of what manual therapy is, when the fact of the matter is they're very much integrated with each other. From the first time the patient walks into the office, the experienced practitioner should be able to have a conversation with the patient and understand what their expectations are, and then develop that therapeutic alliance, develop that ability to pull that into that patient's unique treatment. And, it kind of goes back to even learning about basic interviewing skills. So, for example, how would we ask a patient about their pain, or how would we ask a patient about their motion, or how would we ask a patient about, did this particular movement that I just asked you to do, did that make you feel better or did that make you feel worse? And, one way you could ask that question is, so did this movement help you, which you're kind of biasing the answer, or did this movement make you hurt more, or did it affect you and you have a worse outcome? And if the patient has to deny the negative outcome and support the positive outcome, I think that's one of our interviewing skills that the biopsychosocial is so intertwined with orthopedic manual therapy that we kind of tend to take it for granted in teaching it, especially at entry level.
Yeah, I agree with both of your answers, of course, and there are a lot of points in there that reflect back upon my educational career. And I think one of the important points here, and you've both alluded to this, is the fact that I didn't just say my education, I said my educational career. I went to school, I got my physio degree, I started working in a clinic, but that was just the first step of the process. And like every new grad, I was a little bit lost. I was a little bit confused. I wasn't always happy with my clinical outcomes. And then it was through residency training, fellowship training, and then my doctoral degree that I really had the time. I had the exposure to high-ranking clinical and academic experts. It was through that entire process that I learned how to integrate and intertwine all these different things. And to tell you the truth, at this point, I can't even conceive of accurately dosing my manual therapy without considering, for example, psychological and social variables. It's just part of the process. And it's one of the things that I see inexperienced clinicians doing all the time. They're pushing too hard, they're pushing too soft, or they're not using that, in theory, downtime during manual therapy to, for example, educate their patients about pain science research and all these other things that our patients probably don't know about, and that we can be doing two things at the same time to try and get more of a positive benefit.
I think that's a good summary of both of our statements, and that's spot on with what we're trying to convey in this editorial is how do we actually present that in an educational environment, right? Where, as Jodi said, we're separating out the psychosocial in a different class. And, I'm separating out the neuro in a different class, and I'm putting the bio-orthopedic stuff in a different class. Now, how do we package that? I think that's kind of the conundrum for all of education right now. How do we do a better job at pulling all those aspects together to produce a better entry-level practitioner?
Well, and I would also say, I think it's very difficult to replicate what that looks like, even if you try. So, we have done role playing. So this person's going to be the patient, this person's going to be the physical therapist. So you can try to bring in, they have this laundry list of comorbidities, okay? They have issues going on at home. They have stress in their life. They just lost their job. They lost a parent. But it isn't really until you get out there and you actually have a real person who's gone through this versus role playing that it really starts to hit home, I think. And so, the integration of it, everyone should strive to do it. I completely agree. I think it still is difficult though until you get out and actually interact with that real patient in front of you.
So this is a tiny bit off topic, but do you think that the current model of physical therapist education in the U.S. is sufficiently long for there to be any sort of approach that'll accomplish that true integration?
That's a good question. Go ahead, Jodi.
I don't know if I want to take that one first.
I'll take it first. And I'll say I don't think there is. It's impossible, isn't it? Like, isn't this the whole thing? People like you and people like me, we've graduated, we've worked, we've done residencies or fellowships and doctoral degrees, and I don't know if it's possible, and I hope it is, and I hope that folks like the two of you and your colleagues can figure it out, because I want new grads to come out spectacular, but I have yet to see it, and that's just a part of reality right now, isn't it?
I was laughing. I totally agree with that. I was laughing. Like, the last thing we want to do is add more credits to the curriculum or add more length to the curriculum at entry level, right? I think we do have to get better at saying that here's what we expect of an entry level performance. And then there's other things that you are going to have to figure out when you get to the clinic, right? Like in Jodi's example, how many clinical vignettes could we do with the students playing the role, or even using simulated patients in a simulation lab? That maybe gets at some of these things a little better. However, but you still don't integrate that until you get into real time in the clinic and, fail a couple times and pick yourself back up, dust yourself off, and try it the next time, right?
Going back to the time thing, do I think it's a long enough time frame? I think there's areas within the different curricula that could probably be cut back and really focus on areas where it seems to be lacking. But that then leads to more potential standardizing of the different curricula, which, that's a whole different conversation, because of course CAPT has the requirements and it has all of the areas that you need to meet. but how programs are meeting that can be very different, wildly different. So I do think that there's a way to minimize some of the content. I'm not going to say what content or where, because I think everyone could argue and debate what that is. But as far as a time frame for a program, I'm not sure how I feel about that. But I just think within where programs are working now, there's probably some room to be able to spend more time on things that are being seen on the clinic side or hospital, wherever it is, whatever setting you're working in.
Those are, of course, wonderful answers, and I agree with them completely. And to bring things back a little bit towards the whole conversation of manual therapy, I personally find it interesting that paper, like the one that you've written, is necessary because, we tend to think of these things, as you've said before, in a compartmentalized fashion. This is biopsychosocial, this is orthopedic manual physical therapy, and they're on different sides of a spectrum. But if we go back to the International Federation of Orthopedic Manipulative Physical Therapists, which is, of course, our parent organization here at AOMT, they've had in place a definition, and anyone can look this up on their website, for manual therapy that's been, I guess we'll say it's been their public stance on the definition of manual therapy since 2004. I did not go back to see how much this definition changed from their previous definition, but, and I'm quoting IFOMT here, orthopedic manual physical therapy is a specialized area of physical therapy for the management of neuromusculoskeletal conditions based on clinical reasoning, using highly specific treatment approaches, including manual techniques and therapeutic exercise. So at the initial onset of reading that definition, you say, yes, it's a little more broad than just touching people and using this joint technique or that friction massage. But they go on and say, very specifically, orthopedic manual physical therapy also encompasses and is driven by the available scientific and clinical evidence and the biopsychosocial framework of each individual patient. And when you read that definition, they literally throw the word biopsychosocial framework into it. And it's just, as a result, it kind of surprises me when, we end up having to have these conversations. They are integrated already, or at least they should be. So, part of my question here is, why are we still arguing about this?
That's a great question again, I think. And why is an editorial like this needed again? I think we need to bring it back into the awareness, especially of educators, that sometimes might not be given enough time to help students, entry-level students, develop their hands-on skill. I think we still have part of a debate about what is physio in general, and should it include a hands-on component? What do we use the hands-on component for? Do we use it as part of our examination? Is it something that the patient comes in expecting that they're going to have someone actually touch them and there's some therapy in the actual human contact? It's the idea that if students aren't provided with enough time to gain perhaps confidence in their own skill to palpate something that is tight or something that is loose or something that moves or something that doesn't move, that then they're going to struggle with these things and portraying that to the patient. I think one of the articles that was looking at recently is the O'Sullivan article on cognitive functional therapy. And within that, the framework there is that we should be using manual therapy and hands-on to validate that patient's illness experience and to talk to them and to have that conversation. Hey, this feels like, I would expect this in where you're at with this acute type of syndrome that you're coming in, or possibly if they're in more of a chronic, 6 months down the road situation, that the acute inflammation is over and you're palpating things and you're like, this is 6 months past now. I don't expect this to be, your tissue is having this abnormal response right now. So how could I be able to validate that patient's illness experience if I don't feel comfortable in those basic assessment skills I think that manual therapy hands-on can provide.
And I think some of that research is getting a bad rap for saying don't touch your patients at all, right? I think that really, if you dial in on it, it's not saying that. Even the pain neuroscience, they're not ever, that's not what they're studying. But I think if you talk to some of those authors, I'm not speaking for them, but I just believe, they were trained as physical therapists. They know the aspect of the hands-on. They know the patient contact. I think that we talk about a pendulum swinging. I think because that research is out there now, people have just perceived that, oh, we should no longer do manual therapy at all. But again, if you're teaching the student or the resident or the fellow to really look at all of those aspects, I don't think that they would say that at all. I don't think they would say you shouldn't do any physical therapy or any manual therapy whatsoever. I think there's just a few individuals who've expressed that on social media who feel very strongly about that. But in other regards, I don't think that everyone would agree with that, because it is still part of our profession and it is still how we are trained to treat our patients.
And to dive into that just a little bit further, if you look at the research enough, or if you look at enough different studies, it's really impossible to even pull them apart, because we know, for example, that the physical contact and the joint mobilization, etc., can impact the central nervous system and the way the patient thinks about you or feels about you. And likewise, if you're going to sit down and start to do some education and pay attention to things like maybe sleep hygiene or pain science education, etc., we know that can calm down the periphery. The two, and we've said this before, the two are inextricably linked, and there's no way to really break that connection. Psychology involves biology. Biology involves psychology, and we can't rip them apart.
Yeah, exactly. I would say, that's the enjoyable part of clinical practice, right? When you have those cases which some people might term difficult, or I would say more challenging, perhaps it's trying to almost figure out what the chicken and the egg thing is there, which actually came first, and how can we best guide our interventions to help each individual patient.
And of course, the outcome is always the most important thing. We are, after all, clinicians. And, just to give one example, let's say the patient comes in. This actually happened to me last week in the clinic. The patient came in with an acute exacerbation of a chronic back pain, and they very much had kinesiophobia going on. And one of the things that was really important was I talked to them about, whether or not this painful tissue in their back was likely to be damaging. And, the essential message was, you're hurting yourself. You're not harming yourself when you move. And that was good for them, because they're of the age where, an x-ray was taken and some things were seen, and, this person is starting to catastrophize. That in itself, for this patient, didn't really change how they moved. But when I got to the physical exam portion, I was able to find that restricted segment. I was able to push on it, get it moving, bring their pain down. They got up off the table. They could suddenly walk better, move better, bend better. If one treatment gets me where I'm going and not another one, then that's the treatment I want to focus on. And as we all know, it's not the same treatment for every patient.
But I think the big point about what you just said is you educated them, right? So you talked to that patient and you used words, I'm guessing, that weren't harmful, or you didn't induce any thought viruses that may have scared that person more. And you got them to the point where they were willing to move. And because it wasn't going to harm, it would just hurt. They were willing to move. They let you help them. And then boom, they were able to move more. So I think that's something with entry-level residents and fellows, and Will alluded to this earlier and said this, but the language and that ability to take a really good history and communicate with patients, that is really difficult to do. And I think a lot of entry-level students, you write your list of questions out and then you just go down the line. What's your pain right now? What makes your pain worse? What makes your pain better? What activities can you not do? There's just this laundry list, where learning really how to take that good history and just listening to your patient is probably the most important element of all of this. So even before you get to that manual therapy, that's the part that matters to help guide where you're going to go, and if you do get to the manual therapy piece of it.
And I would add to that then too, after you performed that mobilization and helped them move better, you did the retest and they could see for themselves that they had that buy-in then as well. I think, our standard procedure then would be, well, let's follow that up with an exercise, or let's follow that up with some type of new movement to access that new range that they haven't maybe experienced for a while. And then let's repeat that over the next few days until we can get you back into the clinic again. And so there's multiple layers again that we've intertwined there, that cognitive idea that I wasn't moving before and now I am moving, and how powerful that can be, that experience. And then now I've got this new exercise that uses this new motion. Hey, yesterday I was able to do this motion, so I should be able to do it today. I think it really is a beneficial part of the treatment, again, where we integrate the manual therapy, the therapeutic alliance, the pain neuroscience together. It's such a more powerful response.
I, of course, agree with all of that. And I think my new favorite phrase now, and I don't think I've ever heard this before, is thought virus.
I think I have to credit Will. You might know Mary Beth Geiser is the person who introduced me to that. And she's on our academic and clinical faculty SIG too.
Oh yeah, we have to give her a shout out for the thought virus concept, right? That we've all kind of used and integrated with that, right? It's like danger in me and safety in me too. I think that comes from the other side of the globe as well. But that kind of goes into that idea, the thought virus. And if someone's got that thought virus, like Stephen had that patient with the fear avoidance beliefs and kinesiophobia, you spend a good time of your initial assessment or your follow-up in like talking them off the ledge. Hey, what's going to happen if you move this way? Well, let's find out. We're in a controlled environment, right? We just moved that way sitting. What happens if we do it standing? And let them explore. That's the experiential learning piece too, I think, that we kind of bring with the manual therapy and the exercise integrated.
Yeah, that's all spectacular, and it's that global approach that's really, I think, most valuable. And speaking of which, we could talk about this topic ad nauseum, but that would not be in anyone's interest. Let's move towards the thing that you want, and you mentioned this in the editorial, the thing that you want to start teaching, integrating, etc. There's a specific paper that you cite. There's a specific model that you refer to. Can you give us a general description of what that is and why you think we should utilize it?
I think you're referring to the Joel Bialski's model, the publication in 2018, DScPT. And I think when we looked at this model and having these conversations with the academic and clinical faculty SIG, I think that this model might just pertain to more than just manual therapy. I think it actually pertains to more physiotherapy in general. So you could put almost any intervention in there, and this is perhaps a model that was designed for research, but maybe we could use it more to help us understand how we can teach these different concepts in entry level and beyond. I think that if you have a copy of that article, I think Figure 2 is really the most relevant to our discussion. And in this model, they divide it up into 3 different zones. And the first zone is really where a lot of this thought process comes in. This is where the patient walks into a clinic, which is a specific context that all these interactions come about. And then the provider actually applies some type of a mechanical stimulus. But just remember that when they apply that mechanical stimulus, whether that's a mobilization or even an assessment technique, it's within that context of that clinical environment that's applied to the tissue. of the patient. And then you start to think about the mediators and the moderators to that interaction, and how those both affect what can happen next in zone 2. But really, when we talk about zone 1, I think we've kind of conceptualized that to being good at your impairments and your evaluation skills, thinking about things in terms of tissue tension, strength, tissue length, those kind of things. So getting good at your basic physical exam skills in that zone 1, so that you can understand how the stimulus that you're applying to that patient, what are your expectations of that as a provider? Are you expecting it to be that tight? Are you expecting it to be that restricted? Are you expecting it to be relatively loose compared to segments above and below? And then how much input do I give it, and how much response should I get back from that tissue too? Am I able to, feel some muscle spasm that might take place next to that area that I'm working at? Am I able to read that patient at the same time, and their body response to the stimulus that I'm providing? So again, for zone 1, based on my clinical decision process, is this an acute patient? Should they be in more of a symptom modulation type of box right now, or should I move them more into a movement control type of box, right? So can I start to put them into a mobility category to think about our clinical practice guidelines? Can I put them into a restricted range type of mobility category, or is this more of a stability category, which is more of a movement control? And now we start to talk about like zone 2 in Joel Bialski's model, and what are all the neurophysiological responses that happen underneath the surface, maybe that we can't necessarily detect in the clinic, but they definitely have effects on movement control and the responses of the tissue.
And I think just this zone 2 right here, I think this is helpful for students to understand. When I was learning, this was not out. Obviously, his model had not been developed yet. And we were very biomechanical in all of our approaches to manual therapy specifically. And I think that for students, this understanding of this zone 2 will relieve a lot of students, because often with the biomechanical approach, you're trying to make sense of all that in your head, and you're trying to really feel things and what's moving here, what's moving there. And it's difficult to do that. We've shown in the research, not we, people have shown in the research that palpation reliability and our ability to perceive movement is not so wonderful. And so I think sometimes when they perform a manual therapy technique, if they have this understanding of what's occurring in zone 2, that neurophysiological response or that control alt delete, then it makes much more sense to them, and they can feel a bit more confident in what they're providing to the patient.
And then I think from there, we got to step into zone 3, which is a little bit more, an integration of the prior 2 zones. And it's also a summary of our therapeutic alliance with the patient then at that time. So certainly zone 3 is kind of like the output or the outcome of that clinical interaction. So it's more of a summary of, hey, what did we do as the provider, and what were our expectations as the patient, and was this a movement control type of response that had something relatively quickly alleviate or improve? And so that's what we would expect. Certainly when we're applying manual therapy, we're looking for some type of a quick response, especially in those patients with movement control or motor control types of issues that have a lot of fear. Once we can get that area to move and that usually presents itself within a pain inhibition and some type of beneficial functional outcome type of improvement.
One of the messages that I'm, of course, hearing here is the fact that there are a lot of moving parts. There are a lot of variables at play. There are a lot of different pathways that any given patient can take from start to finish, which means this is relatively complicated, which all of us know, of course, as clinicians and educators, etc. It's the type of thing that we have to practice, we have to be bad at, we have to keep practicing, we have to get better at, we have to learn and pull from the older, biological, biomechanical, chemical, histological type evidence, put it into context with the psychosocial variables and how that and all of these different variables impact our patient in that moment, and then move forward in a way that hopefully gets us where we're going, which is a positive clinical outcome.
So you can understand how complex this is with educators in the entry level and residents and fellows. This is, like you mentioned, so many different moving parts, but I think it just really, our idea is to open the conversation and to get people talking about this and, maybe brainstorm AMPed conference. We were talking about attending the AMP conference before. How many people are there? And just really sit down with other people with like minds and think about how this could really progress in how we teach our students.
I think that's a great idea. And if there is a group of physical therapists around that can sit down and put all of this into context and come up with a way to bring it to an educational setting in a productive, effective, and efficient way, then I think it, of course, would be the AMPed crowd. So if that's a challenge that people can throw out there and have it become a reality, that would be absolutely amazing.
Yeah, I would agree. And just to summarize, that you can't separate these things and expect the same results to happen. And I think that's what has occurred in research, and then that's also what's occurring at entry level and maybe to degree some residency programs where you're expected to perform a mobilization or a skilled technique in one way or one direction. And that's when the patient presents with X, you're supposed to do Y. And that's not this clinical reasoning, narrative reasoning that we're talking about teaching our students to really excel at combining manual therapy and the biopsychosocial model, which really, in my mind, should not be segregated. They are completely together.
Well, this has been absolutely fascinating. I highly recommend that all of our audience check out not just the editorial we're talking about right now, but in addition to that, I will put in the show notes a link to the paper that we've been referring to from Bialowski in 2018. And I think from the manual therapy crowd in general, we can expect a lot more work on this topic to come out in the future.
We certainly hope so. I think Jodi needs some more people to support the AMP clinical academic and clinical faculty SIG. So that would be a great place to continue this conversation as well.
Yeah, I absolutely agree. I was thinking that if we could get people on board that want to be part of a little focus group or somehow, like I said, to just sit down and brainstorm, that would be great. We're always looking for new members and people who will want to be engaged and help drive forward a lot of our things that we're working on.
Excellent. Let's leave it there. Let's hope that some of our listeners are on board with that idea and that they reach out. As is always the case, your contact information will be available in the show notes. And until next time, let me just say it's been a pleasure.
Thank you, Stephen.
Thank you so much.
The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes. This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT.